Uh, Good evening. Thanks to the organizer for inviting me to share our experience from Dhaka, Bangladesh, especially Dr. Amitabh Chattopadhyay. So I'm from Dhaka, Bangladesh, and you know Bangladesh is widely acknowledged to be a development success story, having reached lower middle income status less than 50 years after its independence in 1971. And this is my hospital. It's the largest children's hospital in Bangladesh, and it is a government-supported tertiary level public hospital for children. And transcatheter intervention in neonates presents unique challenges in Bangladesh due to limited resources, unavailability of hardware, cost of procedure, of course, taken care by the parents, and low birth weight infants born more here. Sepsis diagnosis and delayed referral. Transcatheter interventional therapies for children continue to evolve at a remarkable rate in Bangladesh. In neonate, less invasive interventions are preferred because open heart surgery can be performed at few centers and is associated with high mortality risk. The primary consideration of the pediatric cardiologist should not be whether it is possible to perform such techniques, but whether their clinical utility, morbidity, mortality justifies a non-surgical approach for their patient. However, careful technique, proper planning, and safety measures reduces the incidence of complications. So, objective of my talk is to share our experience, our patient profile, type of interventions, complications, results of all neonates undergoing transcatheter intervention in Bangladesh Shishu Hospital Institute since June 2014 to June 2022, 8 years experience. So the spectrum of neonatal intervention as usual. So we have done ductal stenting total 152, out of that neonates were 113. Balloon pulmonary valvuloplasty done in 17 neonates, balloon aortic valvuloplasty in 14 neonates, balloon angioplasty of coarctation in 81 neonates, RVOT stenting in 1 neonate, pulmonary valve perforation done in 3 neonates, and of course the oldest intervention, balloon apical septostomy, done in 143 neonate. So if you see the distribution of neonatal intervention year-wise, you can see that the interventions is increasing day by day, and it was except the COVID year in 2020. Last year we have done 39 interventions excluding balloon apical septostomy. And the gender-wise, male preponderance is always there. And with balloon angioplasty of coarctation, total number of patient neonates were 31, and mean weight was 2.8 kilo. Mean flow time was 9.8 minutes, and there was additional defects like BSD 7 patient, ASD 12 patient, PDA 5 patient, and balloon aortic valvuloplasty in bicuspid aortic valve in 3 patient. And this out of 31 patient, severe LV dysfunction was there in 19 patient, and there was statistically significant reduction of the mean gradient after the procedure, and 6 patient mortality was 6 out of this 31. Balloon aortic valvuloplasty done in 14 neonates, and mean weight was 3.6 kilo. Mean flow time has increased to 20 minutes, and there was some additional defect coarctation, and 2 of these coarctation patients we have to also angioplasty need to be done, and LV dysfunction was observed in 6 patients, and there was significant reduction of the mean gradient after the procedure, and 4 patients died after the procedure out of this 14 patients. Total number of neonates for balloon pulmonary valvuloplasty was 17, and 11 patients were critical, having critical pulmonary stenosis. Mean weight was 2.6 kilo. Mean flow time was 37 minutes. And mean gradient reduction was significantly reduced, mean gradient from 66 to 16.5 millimeter. There was some immediate complications like RV dysfunction, transient bradycardia, and cardiac arrest. So you can see this is a balloon pulmonary valvuloplasty patient. So what we do in neonate, we used to bring out the air through the PDA out of pulmonary through the femoral artery. So the trackability of the balloon and the stability of the balloon is more. And mortality was 5 out of these 17 patients. So there was significant improvement of the oxygen saturation after balloon pulmonary valvuloplasty with critical pulmonary stenosis. Ductal stenting, we done about 113 cases in neonates. Most of the diagnoses were top pulmonary atresia, 45 patients, pulmonary atresia intact IVS, 33 patients, single ventricle of different type like double-ended left ventricle, tricuspid atresia, unbalanced complete AV canal with pulmonary atresia, 30 patients, CTGA, VSD, pulmonary atresia, 5 patients. Mean weight was 2.9 kilo, and two patients were premature, and 11 patients born to diabetic mother. There was associated non-structural cardiac anomalies present in 19 patients, and most of them are anorectal malformation. Dextrocardia is observed in 13 patients, and right aortic arch is associated with 16 patients, and mean fluoro time was 42.5 minutes if we consider from the beginning to recent years, but our recent years, this mean fluoro time has reduced to 10 to 15 minutes. The mean length of duct was 15.4 millimeter, and length of stent we chosen was around 16.7 millimeter. And the diameter of stent, mostly we use 4 millimeter stent because of two reasons. One is unavailability of the smaller stent, and second is we preferred biventricular kind of patient like top pulmonary atresia. We preferred 4 millimeter stent in small children for longer duration of palliation. And we use drug-eluting stent in 13 patients, which also gives longer duration in biventricular type of situation like top pulmonary atresia. Additional procedure done bilateral septostomy in 26 patients. If we see the approach of ductal stenting, we mostly used femoral artery in 62% of cases. And earlier we used femoral vein for vertical duct, and nowadays we use mostly prefer axillary artery for vertical duct. So if we see the duct morphology, most duct we did stenting was intermediate type of duct, that is the duct originates from distal arch 41.7%. Next is vertical duct from undersurface of the aortic arch 22.7%. Usual duct from proximal descending aorta 18.2%. Indirect duct from any subclavian artery 14.4%. And we did one bilateral ductal stenting. So this is a 6 days old neonate. You see a vertical duct from distal arch, and this patient we could successfully done stenting from femoral artery, and this is the final results. And this is a 24 oldest neonate. This is, you can see, this is a vertical duct from distal arch, but the duct is very tortuous, and somehow we could manage stenting from femoral vein, and this is the final result. And this is a 10 days old neonate, where we this is also a vertical duct from distal arch, and we did this stenting from axillary artery. So there was a significant increase in the saturation after ductal stenting. And the complication related to the procedures are vascular injury in 3 patients, acute duct thrombosis happened in 2 patients, duct spasm happened during manipulation of where 6 patients, stent, 1 stent embolized and one stent migrate, but we could this patient we could successfully recapture, and because the wear was there, and we could position the stent in proper position. And there was overshunting in 14 patients because we use some a bigger stent, a smaller children, because of mostly in biventricular situation for longer palliation. And there was a follow-up. We found new internal proliferation in 15 patients, and we have seen less new internal proliferation in drug-eluting stent, and there was some kind of mild jailing of either left or right pulmonary happened in 7 patients. So mortality, 21 patients died after procedure, that is 13.8% mortality. And during follow-up, 8 more patients died. And the next intervention, the oldest intervention, is balloon atrial septostomy. We did 143 neonatal balloon atrial septostomy. And the mean weight of the patient was 2.7 kilo and mean age was 23 days. And we have published our data, and we have shown, we used to do this in the cath lab, and we showed that there was significant improvement of saturation and significant improvement of the gradient across the atrium after the procedure, and the size of ASD, there was significant increase in the size of the ASD after the procedure. And we found 6 patients to have coronary artery anomaly. Those patients we suspect to have coronary artery anomaly in echocardiograph. We used to do angiogram. And this is one of the patients where we have shown LCX from RCA. The main complication for septostomy was sepsis, and we found femoral venous obstruction in 4 patients, and which we realized when these 4 patients come back to us for cardiac cath. So after that, we even with every unit, even if it is a septostomy, we used to heparinize for 24 hours. So mortality from septostomy was 16%, was 11%. It's mostly because of sepsis. One RVUT stenting we done in a neonate, which is a TOF patient, using a coronary stent. And this is my final slide. We have attempted several pulmonary valvotomy, but we are successful in 3 patients to do pulmonary valve perforation using CTO guide wear. And you see, we brought out the wear through by using a snared catheter and out of femoral artery. So this gives us a good trackability and stability for balloon dilatation. We did graded balloon dilatation successfully in these 3 patients. So overall mortality was 16.1%, and which has decreased last 2 to 3 years is 12 to 13%. In conclusion, percutaneous cardiac intervention in neonate is safe and effective, especially in resource-limited setup. It requires proper diagnosis, stabilization, prompt intervention, teamwork, and long-term follow-up.
Sorry, your time is up. If you can just
this is my last slide. Variation in anatomy, patient size, and poor general condition at presentation add to the challenge of carrying out these catheter interventions. Early identification and well-planned catheterization procedures improves outcome. Thanks for patience hearing.